Welcome to our three-part cardiorheumatology presentation. My name is James Roberts. Cardiorheumatology pertains to the repurposing of agents traditionally used by the rheumatologist in the treatment of inflammatory joint disease, colchicine, allopurinol, chondroitin sulfate, and methotrexate, instead to attenuate the oxidative and inflammatory stress that underlies and drives cardiovascular disease. I can give this presentation, and I could give other presentations with names such as cardioneurology, cardionephrology, or cardiohepatology. I can do this because Mother Nature created a finite number of inflammation and oxidative stress amplification pathways. They're designed to protect us from our natural predator, and our only real natural predator over the course of human evolution is infection. When these pathways are inappropriately activated, not due to real infection, but instead by oxidative and inflammatory cues that our body perceives as infection, then inflammatory disease, including cardiovascular disease, inevitably follows. If we understand how specific substances block these pathways, relieving symptoms and improving clinical outcomes in disease states affecting the heart and great vessels, we can then use these substances to block inflammation and oxidative stress in every other organ system. With the science available to us today, I don't think that we need to confine ourselves as doctors of cardiology, neurology, psychiatry, or doctors confined to any other organ system. Rather, we can all become doctors of pathophysiology, understanding first how things are supposed to work, what Mother Nature planned for us, and then understanding how things go wrong to produce disease states. I've been in practice for 31 years and describe myself as a practitioner of integrative cardiology. I've carried out somewhere between 5,000 and 10,000 cardiology invasive procedures. Someday, my bone marrow is going to start glowing, given all the radiation that I've been exposed to. I wasn't very careful about this when I was younger. I'm now in my 60s with graying hair to show for it, and my goal is to minimize our society's need for invasive medicine. I want everyone to be as healthy as I am. I still send patients for angiography, stent placement, bypass surgery, and now fibrillation and percutaneous valve replacement, cool advances. And I use all the drugs the other guys use, but I complement this standard turned allopathic cardiology with all the nutritional and detoxification methods that I've learned. And we're involved in clinical trials of new drug and new non-drug approaches. Over the years, I've completed the coursework and passed the written exams in chelation therapy, oxidative medicine, and bariatric medicine, and I'm an advanced fellow in anti-aging and regenerative medicine. That was a lot of work. I completed modules 1 through 8 of the fellowship training program, reviewed 50 webinars, passed written and oral exams, and submitted case studies. This was a great learning experience, and I now teach within the fellowship training program and with other integrative medicine physician training programs. This year, 2017, I gave 18 hours of presentations at 7 meetings. I was supposed to speak at one more in San Juan, but we got Hurricane Irene out. What I'm doing now is to create these voiceover PowerPoints corresponding to these presentations, as well as past and future presentations for the interest of practitioners, my patients, and people who never want to become patients, people who simply want to learn how to optimize their health. None of this should be a secret. These discussions are designed for the integrative medicine practitioner and as such are detail-oriented with a heavy emphasis on biology. As in integrative medicine, we want to know how things work. If you're not a healthcare provider, some of this biology will be new to you. It's not important to memorize or dwell on each point. Rather, follow along, pick up as much chemistry as you wish to, and gain an appreciation of how well designed is our pathophysiology. Whether you believe in creation or Darwinian evolution, we've got a lot going on inside us, a lot more than a computer ever will. I will repeat key points and themes in this presentation and in others, and many topics touched on in this talk will have their own 2 to 3 hour presentations. Just check the listings on heartfixer.com. So now let's begin our cardiorheumatology series with part 1, which focuses on colchicine. I describe myself as a practitioner of integrative cardiology, but my formal training is internal medicine and invasive cardiology, and I am board certified and university trained in those disciplines. Stated otherwise, I was taught, and over the first 10 years of my career, I practiced as I was taught, that the proper focus of cardiology is on anatomy. There is a fixed blockage, a concretion, compromising the supply of oxygenated blood, rendering it insufficient to meet the demands of the exercising heart muscle. So my job was to carry a coronary angiogram and determine the severity of the stent, the narrowings, and then make a recommendation as to how we could best resupply oxygenated blood, either with a percutaneous intervention or with bypass surgery. If the pattern of blockages was not amenable to a resupply procedure, we would use drugs to decrease demand. Beta blockers, calcium blockers, nitrates to lower heart rate, blood pressure, contractility, to decrease the demand of the exercising heart muscle for oxygenated blood, which is in short supply due to this fixed lesion. Cardiology was all about dealing with supply and demand mismatch. And of course, this is an appropriate approach to the patient in crisis. If you're having chest pain because you have a 99% narrowing, we wish to resupply the heart muscle with oxygenated blood with a revascularization procedure. This makes sense. But as we all learned, if we focus only on supply-demand mismatch, if we focus only on established lesions and ignore the circular lesion, the abnormalities in vascular biochemistry and cell biology that caused the plaque to develop in the first place, well then the patient's going to be back with more trouble. If we focus only on advanced lesions and on the circular lesion, we will not be preventing this disease in the individual and within our society. Deep to all the other risk factors is oxidative and inflammatory stress. The other risk factors relate either as cause or consequence to inflammatory stress and oxidative stress. These are the key driving forces underlying atherosclerosis that we must identify and resolve. About 15 years ago, we began to conceptualize atherosclerosis as a maladaptive response of the acquired immune system to what it perceives as infection of the artery wall with oxidized cholesterol. Within this paradigm, we wish to lower your cholesterol, block its infiltration and trapping within the artery wall, block lipid oxidation and immune dysregulation. More recently, we're learning that cells of the innate immune system, our first-line defenders, regard crystalline cholesterol within the vascular wall as a danger signal. Indeed, acute coronary disease and acute gout share a common pathophysiology, one that we can blunt with colchicine. To initiate either the sterile or the acquired maladaptive immune responses to vascular wall cholesterol, we need some degree of oxidative stress to prime this inflammatory process. Once the inflammatory process is upregulated and ongoing, there's going to be an outpouring of free radical mediators. We can think of oxidative stress as both the kindling and the bonfire of atherosclerotic inflammation and cardiovascular disease. So what is oxidative stress? It is an excess of free radical species. What are free radicals? Well, not a communist or an anarchist or an unrepentant terrorist or other ne'er-do-wells and blackguards. Rather, oxidative stress refers to generation of free radicals above and beyond your ability to neutralize them with your antioxidant defenses. A free radical is an atom with 1 as opposed to the normal 2 electrons in its outer shell. It is unstable and reactive. It's going to snatch an electron from an adjacent atom, quenching its thirst for electrons, creating a new free radical, which will snatch an electron from the next atom. A chain reaction will occur, damaging the cell, damaging the organ, leading to disease. So we're constantly generating free radical superoxide as a byproduct of our normal metabolism and housekeeping functions. So Mother Nature gave us superoxide dismutase to convert superoxide to hydrogen peroxide and catalase and glutathione peroxidase to degrade hydrogen peroxide to water. And this is important that we neutralize our free radicals. If not, superoxide can be transformed into the very dangerous free radical hydroxyl to peroxynitrate to hypochloric acid. So Mother Nature gave us these antioxidant defense systems, superoxide dismutase, catalase, glutathione peroxidase, and it's important that we neutralize these free radicals. If not, we can generate hypochloric acid, peroxynitrate. Heavy metals and toxins promote the conversion of superoxide and peroxide into hydroxyl. That's why heavy metals are such a problem for us. So we have our innate antioxidant team, and often it's not enough, and thus in therapeutic medicine, we will treat you with antioxidants and other agents designed to neutralize free radical stress. And I liken it to a football team. There are many sources of oxidative stress. We need to be able to neutralize each and every one. Now, where does this superoxide come from? Well, oxidative phosphorylation, NADPH oxidase, angiotensin converting enzyme, xanthine oxidase, uncoupled nitric oxide synthase, detoxification, and many other organ systems. 2% of the oxygen that we inhale is incompletely reduced in the process of energy generation, creating superoxide. So we're constantly generating superoxide. When we inappropriately upregulate cholesterol synthesis, we activate NADPH oxidase, which generates a great deal of superoxide. So when we are upregulating cholesterol synthesis, we're generating oxidative stress. Angiotensin converting enzyme, which converts a weak vasoconstrictor into the powerful vasoconstrictor and free radical agonist angiotensin II, is upregulated in unstable coronary disease, generates a great deal of oxidative stress in the vascular wall. We need to block that. Xanthine oxidase, which we'll be talking about in our second presentation, wastes oxygen, precious oxygen, to generate uric acid and superoxide, and xanthine oxidase generates the lion's share of superoxide in coronary disease and heart failure. The enzyme that generates superoxide is upregulated in coronary insufficiency and in heart failure. If we cannot neutralize catecholamines such as norepinephrine and dopamine, they will auto-oxidize, generating a great deal of oxidative stress. If we generate superoxide, it can react with nitric oxide, our vasoprotective agent, quite rapidly, generating peroxynitrite. Peroxynitrate causes nitric oxide synthase to uncouple and fall apart, and it becomes a superoxide generator. With respect to endothelial function, if you're not part of the solution, you're part of the problem. Nitric oxide synthase, instead of being a generator of protective nitric oxide, becomes a generator of deleterious superoxide. So Mother Nature created a physiology that generates free radicals, and of course she gave us a physiology to neutralize them with our endogenous antioxidants. The problem is as modern man, we're troubled by all these non-intrinsic sources of superoxide: diabetes, visceral adiposity, smoking, airborne pollutants, heavy metals, and organic pollutants. So we're getting clobbered with free radical stress, and we are experiencing essentially biochemical rusting, which is driving forward nearly all of our age-related degenerative diseases. So there's an overwhelming oxidative assault that we're experiencing that we need to deal with. So oxidative stress means something is terribly wrong. So we need to measure oxidative stress and take steps to resolve it. And there's many lab tests that we could do. Lipid peroxides refers to insufficient antioxidants to protect the cell membrane fatty acids from oxidation. This would be akin to oxidation of your LDL, myoaldehyde, and to treat this, we would give you fat-soluble antioxidants. 8-hydroxydeoxyguanosine refers to damage to your DNA due to oxidative stress. Here we would treat you with water-soluble antioxidants. Glutathione is the middle linebacker of our antioxidant detox defense systems. When it's low, it means that you're experiencing overwhelming oxidative stress or you're being overwhelmed by toxins. So we'll measure these and we'll find different patterns in different patients and then take corrective action. This gentleman began working with me 3 years ago. He had recurrent coronary disease, his grafts had closed, he had refractory angina. He was insulin insensitive. He'd eat half an apple, his blood sugar would rise from 80 to 400. He had an autoimmune condition. And of course, this makes sense because he's experiencing rip-roaring oxidative stress. We began to work together. 1 year later, he's a little bit better. He's still experiencing angina, he's still insulin insensitive, but he's improving. And you can see that glutathione was coming up. Now, at this point, he's doing a lot better. He's angina-free for the first time in 5 years. If he eats an apple, his blood sugar no longer goes to 400, and you can see that we're attenuating oxidative stress. We're doing many things to help this man, but they all boil down to resolving oxidative stress, because oxidative stress is driving our age-related inflammatory and degenerative disease conditions. We're going to keep working with this man. Eventually, everything's going to be in the green, and he's going to be a much healthier individual. Oxidative stress gives rise to inflammatory stress, and we can measure inflammation in our lab studies. C-reactive protein, phospholipase A2, fibrinogen, myeloperoxidase. Quinolinic acid refers to tryptophan being shanghaied to generate inflammatory mediators as opposed to generating serotonin and melatonin. That's why when you're inflamed, you're depressed and you have trouble sleeping. Oxidative stress gives rise to inflammatory stress. What is the mechanism? Nuclear factor kappa beta translocation. All of our immune cells, our mononuclear cells, have threat receptors in their cell membrane that will be stimulated by danger signals or infections such as lipopolysaccharide. That is the material in the cell wall of bacteria. Free fatty acids, angiotensin 2, interleukin 1 beta, tumor necrosis factor alpha will stimulate these receptors, setting in motion a chain reaction of serine kinases that degrade ICBA. ICBA is the inhibitor of kappa beta. So ICBA kinase degrades the inhibitor of kappa beta, and then nuclear factor kappa beta is released from jail. It translocates to the nucleus and begins to transcribe pro-inflammatory factors, cytokines, chemokines, other inflammatory mediators. This is an appropriate response to infection, but it's an inappropriate response to oxidative inflammatory cues as a byproduct of modern living. Now, hydrogen peroxide, which is generated in the presence of oxidative stress, will degrade ICBA and shoot nuclear factor kappa beta in the nucleus. Stated otherwise, oxidative stress per se is perceived by Mother Nature as an infectious threat. So if we're experiencing oxidative stress, we're going to translocate nuclear factor kappa beta in the nucleus and generate inflammatory mediators. We're going to activate this inflammation amplification pathway. Atherosclerosis is a maladaptive response of the immune system to what it perceives as infection of the artery wall with oxidized lipids. And we're going to mount an immune response, and we're going to activate T cells, and they can be activated in one of four pathways. And in atherosclerosis, oxidative stress will skew differentiation of T cells into their inflammatory mode. If you look at the percentage of your T cells that are regulatory, that quiet down inflammation, prevent autoimmunity, these are Treg cells. If you look at somebody with non-coronary disease, a healthy person, it's 5%, stable angina is 3%, unstable angina 1.5%, someone having a heart attack is 1.3%. The inflammatory T cells, which are Th1 and Th17, rise in lockstep. Non-coronary, stable angina, unstable angina, heart attack. Transforming growth factor beta and interleukin 10 are regulatory, calm down inflammation cytokines. They fall as you go from normal to heart attack. Interleukin 6 and C-reactive protein are Th1 inflammatory cytokines. Interleukin 17, interleukin 23 are Th17 inflammatory cytokines. So your immune system is skewed, it is hijacked towards inflammation when you have cardiovascular disease. And oxidative stress stimulates your immune system to take this pathway. Then we have lipid oxidation when our LDL particles are oxidized. Now, LDL is food. Every cell of the vascular wall has an LDL receptor. They need LDL. But when free radicals oxidize LDL, it's no longer recognized as food. Rather, scavenger receptors on our mononuclear cells, on our first-line defenders, will misrecognize oxidized LDL as a microbe. They will engulf it. You'll have a foam cell, and this initiates the atherosclerotic process. LDL cholesterol itself is not going to cause cardiovascular disease. Oxidized LDL, which occurs when we have too many free radicals, when we outpace our antioxidant defenses, is the underlying initiator and driver of atherosclerotic disease. So, oxidative stress shoots nuclear factor kappa beta in the nucleus and causes inflammatory stress. They both lead to endothelial dysfunction. The endothelial cells, the cells that line our arteries, will activate because there's something wrong, and they will release adhesion molecules to attract white cells to enter the artery wall to investigate what's going on. And endothelial dysfunction is a key mediator of cardiovascular disease. Endothelial dysfunction predicts cardiovascular disease, and death. And we can measure endothelial function in the office with the EndoPAT methodology. And the more risk factors you have, the greater the degree of oxidative inflammatory stress, we will see endothelial dysfunction, which we need to correct. Now, why does this occur? Nitric oxide synthase in a reductive environment, an environment that is not characterized by oxidative stress, will convert arginine, the amino acid raw material, into nitric oxide. Nitric oxide does three important things. It activates cyclic GMP, which promotes vasodilatation of our blood vessels and makes our platelets less sticky. Those are all desirable. It degrades NLRP3, which we're going to be talking about in a few slides, and it supports ICBA. So if it supports ICBA, you're going to keep nuclear factor kappa beta out of the nucleus. You're going to have less inflammation. That's how the system is supposed to work. Nitric oxide will support ICBA and block nuclear factor kappa beta translocation. So oxidative stress leads to nuclear factor kappa beta translocation with inflammation. Nitric oxide, the product of nitric oxide synthase in a reductive environment free of oxidative stress, supports ICBA to block inflammation. Now, when we are generating superoxide, it can react with nitric oxide 3 times more rapidly than it's degraded by superoxide dismutase to form peroxynitrite. Peroxynitrite is a damaging free radical, and it degrades BH4, tetrahydrobiopterin, the key cofactor for nitric oxide synthase. Nitric oxide synthase falls apart and becomes a superoxide generator. And if here we're staining for superoxide in the vascular wall of animal models of heart failure, atherosclerosis, and risk factors, you can see that in these disease states, we see lots of superoxide. Superoxide excess drives cardiovascular disease. Now, if we look at endothelial function, in people who are normal, people with mild, moderate, severe coronary disease, or heart failure, endothelial function is the most important predictor of outcome. The worse your endothelial function, the worse you're going to do. The better your endothelial function, the better you're going to do, because if you have endothelial dysfunction, you have oxidative stress in the vascular wall. If you have oxidative stress in the vascular wall, you have inflammatory stress. If you have oxidative and inflammatory stress in the vascular wall, you're going to have endothelial dysfunction. Insufficient nitric oxide due to endothelial dysfunction will lead to unchecked nuclear factor kappa beta translocation and a chronic inflammatory state. Your body thinks you have an infection. You don't, but your body's response to this mistake will lead to free radicals, inflammatory mediators, endothelial dysfunction, cardiovascular disease. And this also leads to abnormal lipid and glucose metabolism. How does that work? Why should that work? Well, consider, what are the natural predators of man? We have many new predators today: guns, traffic accidents, medical errors, and now drones. Or is it lions, tigers, and bears? Oh my, well, you are wrong there. Actually, our natural predator is infection. Whether you believe in Darwinian evolution or creation, we have been evolving over the past 4 million years. And our natural predator is infection. Infection is what kills us. Yersinia changed the landscape of Europe far more than did Henry VIII, Mussolini, or Hitler. More lives were lost in 1920 due to the Spanish flu than were lost in the trenches during World War I. So we are dying of infection, and over the 4 million years of human evolution, we've become adept at recognizing and responding to this threat to our survival. Now, when we have a real infection, we will experience oxidative inflammatory stress, and the body reads that and upregulates the expression of HMG-CoA reductase. That is the enzyme that generates cholesterol. So we're going to increase the generation of cholesterol, which makes sense because if we have an infection, we need to make white cells to fight these battles, and they need cholesterol for the cell membrane. So our normal response to infection, we upregulate cholesterol generation by upregulating HMG-CoA reductase. That's logical. But when we're fighting infection, we need more than white cells. We need bullets. We need free radicals, and our white cells use free radicals to kill the microbes. So in this process of upregulating cholesterol synthesis, we also upregulate the expression of isoprenoid molecules that in turn activate an enzyme called Rho kinase that puts that puts NADP oxidase together, which is our most powerful free radical generating system. So in our white cells, NADPH oxidase is upregulated, making superoxide to kill microbes. And of course, if we have lots of superoxide, we're going to have hydrogen peroxide. Nuclear factor kappa beta translocates to the nucleus to make more inflammatory mediators, because we want an oxidative inflammatory storm to kill these life-threatening infections. And we need blood sugar. When you have an infection, your blood sugar rises because the serine kinases that degrade ICBA and shoot nuclear factor kappa beta into the nucleus to generate inflammatory mediators also serine phosphorylate the insulin receptor, causing insulin insensitivity. So your blood sugar rises. And of course, this makes sense. You want a high blood sugar because your white cells need fuel. They need high sugar to carry out their responsibility to kill the microbes. So this is all an adaptive response to infection. We're going to make free radicals. We're going to make cytokines. The endothelial cells will activate. We're going to make cholesterol. Our blood sugar will rise. This makes sense when we're fighting a discrete action. NADPH oxidase upregulates to make free radicals. Nuclear factor kappa beta translates to the nucleus. Another inflammation amplification pathway, activator protein 1, upregulates. NRF2, which generates antioxidant detox molecules, is turned off. We don't want antioxidants. We want free radicals to kill the microbes. So we're going to turn that pathway off, appropriate during infection. So this is an adaptive response to infection. Oxidative inflammatory stress, hyperlipidemia, immune stimulation and dysregulation, high sugar, endothelial dysfunction. This would make sense. Mother Nature never makes mistakes. But our problem today is that we're not dying of infection. But as a byproduct of modern living in industrial society, we are experiencing a great deal of oxidative inflammatory cues. Our high sugar, our high fat diet. Belly fat is an inflammation factory. Environmental toxins, leaky gut, allergy, chronic infection, sleep apnea, inappropriate NLRP3 activation, which we're going to be talking about. So these inflammatory and oxidative cues are experienced by Mother Nature as infection. So we're going to crank up cholesterol generation. So the oxidative inflammatory stress, hyperlipidemia, insulin resistance, hyperglycemia, immune dysregulation that characterizes modern man in Western societies is a maladaptive response to what Mother Nature thinks is infection. And we upregulate HMG-CoA reductase, and we're making not just more cholesterol, but more inflammatory mediators. When you were 25, your cholesterol was normal, your blood pressure was normal, inflammatory mediators were not elevated. When you're 45, you're 55, your cholesterol is rising, your sugar is rising, there's all this inflammation because over the years, you've accumulated all these pseudo cues for infection, and Mother Nature is ramping up this pathway, so you get high sugar, high cholesterol, high blood pressure, and you become sick. So this brings up the concept of the unholy pentad of Poling, how oxidative stress leads to inflammatory stress, endothelial dysfunction, hyperglycemia, hyperlipidemia, and immune dysregulation. And you'll notice first there's a problem with this schema here. Pentad refers to 5, and we've got, let's see, 1, 2, 3, 4, 5, 6. So there's a problem here. And this has created concern with Dr. Poling, one of the leaders in integrative medicine in the United States. And some people have begun to call into question Dr. Poling's cognitive abilities. In fact, Life Extension Foundation published an entire article to discuss, Dr. Poling as the face of medical ignorance. Now, I know that Dr. Poling, everyone has strong feelings about Dr. Poling. Some of you, like me, are for Poling. Some of you are against Poling, and some of you were for Poling before you were against Poling. But I think we have to give a guy a break. First of all, Dr. Poling is 120 years old. I mean, that's a long time to be on the face of the earth and practice medicine. Dr. Poling co-wrote The Lion, the Witch, and the Wardrobe with C.S. Lewis. He was C.S. Lewis's personal physician. Working with Al Gore, Poling discovered the internet. And he was the first physician to get involved in electronic medical records. He's on his 43rd different electronic medical record. So, that's a long time to be thinking and innovating. Plus, Dr. Poling practices in Michigan. And as you know, there's a lead problem in Michigan, and it's a lot worse than they're letting on. So Dr. Poling is lead toxic. So the guy's 120 years old. He's been working hard a long time. His brain is addled with lead, so he's having a little trouble counting. So we got to give the guy a break. But, don't worry too much about him. He's still seeing new patients and carrying out invasive procedures on them. So what we're going to do, we're going to help out Dr. Poling and draw a few more lines, and we're going to call this Roberts's Rules of Intimal Disorder. Dysfunction at any one foci will affect all foci. So if you have oxidative stress, I know you're going to have inflammatory stress, endothelial dysfunction, and hyperglycemia. Let's say your blood sugar is 400. We will never see a patient with a blood sugar 400 that doesn't also have endothelial dysfunction, inflammation, and hyperlipidemia, because dysfunction at any one loci will lead to activation of these other pathophysiologic processes. So that will bring us to Kahn's therapeutic corollary. Now, I'm making fun of Dr. Poling because he's my best friend, and he doesn't mind this at all. And he pokes fun at me, and I poke fun at him. And I give presentations at medical meetings throughout the United States, and most of the people there don't live in the Midwest. So I always have something about Dr. Poling. The Poling's theorem, Poling's postulates. So there's always something about Dr. Poling, and we have a lot of fun making fun of one another. Joel Kahn is an integrative cardiologist who teaches in the fellowship in anti-aging regenerative medicine just as I do. And Dr. Kahn not only talks the talk, he walks the walk. He's been vegan, plant-based vegan for many years, and he teaches this to his patients. And I've seen Dr. Kahn's patients. They may have severe coronary artery disease. They go on this pristine, vegan, Esselstyn-Campbell diet, and they do great. So if you have cardiovascular disease, you can change your diet dramatically, and you can stabilize it and regress it, and it doesn't cost you a thing. And Dr. Kahn is the expert here. So anyways, we said that in Roberts's Rules of Intimal Disorder that an abnormality at any one foci will lead to the other. Conversely, Kahn's therapeutic corollary is that correction any one foci will favorably affect the other foci. So if you have endothelial dysfunction and oxidative stress, and I resolve the oxidative stress, I know that endothelial dysfunction will improve. I know that hyperglycemia will improve. So we want to correct as many of these foci as we can, but if we can't correct them all, and I can correct a few of them, I know that the others will improve. Oxidative stress drives cardiovascular disease because Mother Nature perceives oxidative stress as an infection. Think about it. What would cause oxidative stress in primitive man? Primitive man was not loaded with lead and cadmium and organic pollutants. Primitive man didn't smoke. Primitive man wasn't diabetic. Primitive man experienced infection. So when we, as modern man, experience oxidative stress, Mother Nature says it's infection, and then we ramp up all of these pathways, which are adaptive when you have a real infection. They're maladaptive when you're dealing with the pseudo-infection of the inflammatory and oxidative cues associated with living in industrial societies. Now, how do we approach this problem of oxidative stress? Antioxidant support, blocking radical generating enzyme systems, and removing acquired sources of non-physiologic oxidative stress. Now, if we have the luxury of time, we're going to work here. Lose weight, deal with sleep apnea, get rid of heavy metals and organic pollutants that are throwing off free radicals, deal with leaky gut. And some of us have chronic infections like gingivitis or bacterial dysbiosis of the gut. We want to deal with these. And this is the best long-term approach because this is the underlying problem. Of course, this takes time. It takes time to turn around a metabolic ship, slowly and persistently resolving the oxidative diathesis to atherosclerosis. And in someone who is not in crisis, this is the preferred approach. And this is what I do for myself and my colleagues in integrative medicine. We treat ourselves this way. But if you are 65 and you just had a heart attack and you're experiencing oxidative fire, we can't wait 20 years for your metabolic ship to turn around. We need to take action now. We need to throw some cold water on the fire. So we will, if you are experiencing oxidative stress, I will provide antioxidant support. Now I can give you exogenous antioxidant support, EC, lipoic acid, glutathione, etc. And I can use clinical trials in different conditions. Clinical trials have been carried out showing that one or a cocktail of antioxidants provides a specific goal, and I might use that, or I will do laboratory testing and see which type of antioxidants you need. Now, Mother Nature gave us an antioxidant defense system, and these enzymes are transcribed by NRF2, which is nuclear erythroid factor, erythroid factor 2. I don't know how they came up with these names. Anyways, certain agents are pseudotoxins, such as sulforaphane from broccoli, causing NRF2 to translocate to the nucleus, generating antioxidant detox enzymes, and just about everybody in Western society should be taking a NRF2 translocator. Glicidin is melon superoxide dismutase bound to a gliadin molecule to make it absorbable. If you give people glicidin, you will upregulate the expression of superoxide dismutase, catalase, glutathione peroxidase. And if we look at carotid intermediate thickness, which is a measure of your propensity to form plaque, in this study, the placebo patients worsened over time as expected. Those on glicidin regressed. So far, anything that resolves or regresses carotid IMT decreases your risk dramatically. So if your IMT is regressing, this protects you from having events. Pomegranate juice upregulates the expression of peroxidase, a key antioxidant. The antioxidant function of HDL is peroxidase. So in this study, individuals with significant carotid disease took pomegranate or placebo, and there was progression in the placebo group, and there was regression in the pomegranate group. So we will use various cocktails of antioxidants to resolve oxidative stress as best we can. We're throwing cold water on this fire. And we can use drugs. And in all the drugs that we use in cardiovascular medicine that improve your outcome, lower your risk of heart attack, stroke, all of them will lower the generation of free radical species. Now, we talked about how HMG-CoA reductase is upregulated in our maladaptive response to toxins and belly fat and allergy. Mother Nature thinks it's infection. So we upregulate HMG-CoA reductase, we make cholesterol, we activate NADPH oxidase, which generates superoxide, which goes on to hydrogen peroxide to activate nuclear factor kappa beta. So we would want to block HMG-CoA reductase. And indeed, that's what we do. Most of you think we're giving you statins to lower cholesterol generation, and indeed we are, but also really blocking Rho kinase, NADP oxidase, and superoxide. So that's the real reason we give you statins, to lower free radical and inflammatory stress along with cholesterol. And of course they work. This was a study where they took people that had a heart attack and sent them home on placebo or a HMG-CoA reductase inhibitor, and you can see the major event rate over 7 years was 10% with placebo, 5.7% with the HMG-CoA reductase inhibitor, a 45% risk reduction. What was this HMG-CoA reductase inhibitor? That's red yeast rice extract. Red yeast rice extract and amla and bergamot and delta-tocotrienol will inhibit HMG-CoA reductase just as do the statin drugs and have all the downstream anti-inflammatory antioxidant effects. So if you can't take a statin, you can take red yeast rice extract, and we have a 2-hour presentation on this. Renin, angiotensin, aldosterone. When that pathway is upregulated, we activate NADPH oxidase and nuclear factor kappa. Now, angiotensin converting enzyme converts angiotensin 1 into angiotensin 2, which is a vasoconstrictor, and it lowers and that mediates hypertension. So we use ACE inhibitors to lower the generation of angiotensin 2 to lower blood pressure. But within the vascular wall, all the cells have angiotensin 2 receptors. Our first-line defenders have angiotensin 2 receptors. Much of the ACE is present in the vascular wall. It upregulates in unstable coronary disease, and ligation of the angiotensin 2 receptor in the vascular wall activates nuclear factor kappa beta, activates many inflammatory pathways. So we will wish to block angiotensin 2 within the vascular wall, not to lower your blood pressure, but to lower oxidative inflammatory stress. Catecholamine autooxidation. If you're making too much adrenaline and you can't break it down, the catecholamines will auto-oxidize and throw off a lot of free radicals. This is why we might use a beta blocker in your treatment. Xanthine oxidase, which is the subject of our second presentation, wastes oxygen to generate uric acid and superoxide, and we can block this with allopurinol, and that will lower myeloperoxidase, nuclear factor kappa beta, and phospholipase A2. Our present discussion is on colchicine. Colchicine blocks the NLRP3 pathway, which generates a great deal of inflammatory and oxidative stress, including nuclear factor kappa beta and ADPH oxidase. So allopathic preventative cardiology is drugs to lower the generation of free radicals. Statins downregulate NADPH oxidase. ACE inhibitor and angiotensin receptor blockers inhibit NADPH oxidase. Beta blockers blunt catecholamine autooxidation, which throws off superoxide. Allopurinol directly blocks the generation of superoxide. Colchicine blocks the generation of interleukin-1 beta, which will lead to less superoxide. Pentoxifylline blocks nuclear factor kappa beta, less superoxide. These are all pharmaceutical approaches to oxidative stress. They're appropriate, particularly in the patient who doesn't have 10 years to turn around the lifestyle factors that have caused oxidative stress and cardiovascular disease. And this is why these drugs are appropriate. They do have a role. But we don't want to have our brain in the box thinking drug only, and these drugs are useful, but we want to use nutritionals as well to complement the antioxidant defenses of our drugs. And of course, in the long run, you don't want to have this oxidative stress. You want to deal with these lifestyle factors and remove toxins that generate the inappropriate free radical overload that leads to disease. Well, let's get back to cardiovascular disease. That was my introduction. I wanted to talk about oxidative inflammatory stress. Characteristics of this disease. I'm a cardiologist. What is this disease that I'm talking about? It involves deposition of an endogenous crystalline substance within the interstitial space. That is the space between cells. There's an initial mononuclear response. These are mononuclear cells. They have one big nucleus. These are our first-line defenders. They are activated because there's something wrong. You're going to get low-level nuclear factor kappa beta activation. Chemokines, these are chemicals that draw white cells into this area that needs to be investigated by the immune system. Chemokines are elaborated. There's a generalized polymorphonuclear leukocytic infiltrate. These are the neutrophils. These are the effector arms of the immune response that generate a great deal of free radicals. And these are mononuclear, one big nucleus. These are polymorphonuclear when you stain them and look at them under the microscope. Then you get the polymorphonuclear leukocytic infiltrate into the interstitial space, a focal oxidative inflammatory burst, lesional destabilization, and acute onset of symptoms. What is this disease that I'm talking about? As I'm a cardiologist, you might say, well, this is cardiovascular disease with an acute coronary event, but I was talking about gout. Now think about gout. This is a response of the innate immune system to deposition of crystalline crystalline uric acid within the interstitial space. So you've been building up levels of uric acid in your toe, and all of a sudden you have acute gout. Now the crystals have been there for years. Something happens to precipitate acute gout, and there's an infiltration of mononuclear cells and polymorphonuclear cells into that area. There's inflammation, there's an oxidative and inflammatory burst, and you have this miserable hot toe. Now, we can treat gout, we can prevent gout with colchicine. Colchicine is an extract of the autumn crocus. It's been used since the time of Hippocrates to treat gout. And it can be, this is its chemical form that can be made in the laboratory as well. Now, how does gout work? Gout blocks the NLRP3 inflammasome, which is an intracellular threat sensing and response program. Now, we talked about having these threat receptors on the cell membrane of our mononuclear cells for free fatty acids, tumor necrosis factor alpha, lipopolysaccharide. NLRP3 is intracellular. Now, what does NLRP3 stand for? This is a horrible name. Nucleotide binding oligomerization domain-like receptor, purine domain containing 3 inflammasome. So it will then associate with ASC, apoptosis speck-like protein containing a caspase activation recruitment domain, which activates procaspase to make caspase. Caspase is an enzyme that will process nascent, inactive pro-interleukin 1 beta and pro-interleukin 18 into active inflammatory interleukin 1 beta and interleukin 18 that will leave the cell and lead to a oxidative inflammatory outpouring. Now, colchicine blocks NLRP3. NLRP3 is activated in response to phagocytosis of crystalline uric acid into the cell. So we phagocytose crystalline uric acid, we activate NLRP3, we make caspase, and we convert nascent pro-interleukin 1 beta and interleukin 18 into the active cytokines. And if we block it, these crystals simply become rocks. They no longer activate nuclear factor kappa beta. There's no bonfire. Now, what do I mean by phagocytosis? Our white cells, our first-line defenders, they will phagocytose an invading bacterium. There's an invagination of the cell membrane. They surround the invader and they put it into this structure, cystic structure called the phagolysosome. They digest it and kill it. That's how we defend against microbes. Phagocytosis, I think phagocytosis is Greek or Latin for eating. Macrophages are big eaters. They gobble up invaders. Now, the problem here is that when our white cells phagocytose crystals, like crystalline uric acid, you can't digest them. They're not bacteria, they're rocks. So the phagolysosome breaks apart and releases a molecule called cathepsin along with free radical mediators, and that's the signal to activate NLRP3. So when you have gout, it's always a two-step process. I first gave this talk in Dallas, so we'll use the Texas two-step as an analogy. Now remember, when gout is a response to years of buildup of crystalline uric acid in your toe, but gout itself is an acute event. It's a sudden event, and it often occurs following an inflammatory cue like a fever or an infection or a night on the town. So you need some low-level nuclear factor kappa beta activation. That could be inflammation, oxidative stress, or infection. So you're going to make a little bit of this pro-interleukin 1 beta, pro-interleukin 18. Then you phagocytose the crystals of uric acid, and then you have this frustrated phagocytosis. NLRP3 is activated, caspase converts the nascent interleukin 1 beta into the active interleukin 1 beta. You get white cell recruitment and an oxidative bonfire. So it's a two-step process. And this step is going to be blocked by colchicine. So colchicine blocks tubulin. Tubulin are proteins involved in scaffolding of the cell. And if we block tubulin, we can't put NLRP3 together. So NLRP3 assembly is blocked. We don't make caspase. Interleukin 1 beta, interleukin 18 are not generated. White blood cell chemotaxis and infiltration are blunted. No oxidative bonfire. The uric acid crystals are functionally inert. Thus, colchicine will abort, to actually treat the inflammatory response to uric acid crystals, which is acute gout, and it will prevent it. So if you take colchicine and you have a high uric acid, you will not get acute gout because your body cannot respond to crystalline uric acid with an inflammatory response. If you have acute gout, that means NLRP3 is really ramped up. You block it, and you'll block the generation of inflammatory mediators, and in 1 to 2 days after taking the colchicine, you'll feel better. Now, when you take colchicine orally, peak plasma level at 1 hour, and it rapidly declines, a half-life of 12 hours. It's in, it's out. But it is taken up by your polymorphonucleoleucocytes and monocytes slowly with a peak level at 2 days, and it will slowly decrease to nil over 10 days. So if you take a single dose, it's in and out of your circulation, but it's being slowly taken up by your white cells, and that is where it does its work. So if you take colchicine, you don't feel better for a day or two because you have to allow enough time for it to get into the white cells, which is where it's going to be working by blocking NLRP3. You have to take it every day for 2 to 3 weeks, has a half-life of 2 days, and it will concentrate in your polymorphonuclear leukocytes, the cells that are making all the superoxide, 200-fold above the plasma level. So colchicine is a toxin, it's a poison, but it selectively concentrates in your white blood cells. So a dose of colchicine that won't inhibit other bodily functions significantly will inhibit NLRP3, and this way you can block gout. Now, colchicine also will block superoxide. So here we're going to take normal mice, and we're going to administer 3 milligrams of monosodium urate, uric acid, into the peritoneal cavity, the abdominal cavity. And then you're going to get a uric acid peritonitis. You're going to get inflammation of the belly, just like you would get inflammation of the joint with gout. And then at 4 hours, you're going to wash out this area and concentrate the neutrophils, the polymorphonuclear leukocytes. And then you'll see they're making a ton of superoxide because NLRP3 has been activated. They're making all these inflammatory mediators and making superoxide. Then you'll culture them with increasing doses of colchicine, and you can see colchicine puts a halt to that because colchicine blocks NLRP3. Now, we're going to take white blood cells from healthy humans. We're going to look at the total leukocytes, all the white cells, the polymorphonuclear leukocytes, the superoxide generators, and the mononuclear cells, which are the first-line defenders. And you're going to incubate them with uric acid crystals to activate NLRP3 to make superoxide, and then you'll incubate them with colchicine. Now, resting white cells don't make a whole lot of superoxide, but when they're activated by uric acid, they make a lot, and this is blunted with colchicine. The polymorphonuclear leukocytes, at rest, they're making superoxide. That's their job, to use superoxide to kill invaders, and they get cranked up with the uric acid via activation of NLRP3, and then the amount of superoxide will fall with colchicine. Mononuclear cells, our first-line defenders, they organize the inflammatory response, but they don't mediate it. The mediators are the polymorphonuclear leukocytes that make superoxide. So the mononuclear cells don't make a whole lot of superoxide. They make a little bit in response to uric acid, and that is also blunted with colchicine. Now, so colchicine will block superoxide generation by blocking NLRP3, but it has another means through which it can block superoxide. Low-dose colchicine will inhibit superoxide production. Greater concentrations are required to knock out NLRP3 and inhibit white cell infiltration. So colchicine, by blocking tubulin is needed to put NADPH oxidase together. So colchicine will inhibit. NADPH oxidase is such a powerful generator of superoxide that cells in the resting state separate into pieces because you don't want to make superoxide inappropriately. You put them together in response to a real inflammatory or oxidative cue to make superoxide. And pathologically, uric acid will lead to NLRP3 activation and NADPH oxidase formation. Colchicine will inhibit the assembly of NADPH oxidase in response to uric acid. It does not inhibit superoxide production in response to a physiologic stimuli. So we don't think colchicine is going to keep you from making superoxide when it's appropriate to kill microbes, but it'll keep you from making superoxide inappropriately, such as if you are experiencing danger. A danger signal has been mounted because of these crystalline substances such as uric acid. So colchicine inhibits NADPH oxidase in pathological situations as well as NLRP3. Now, how does this relate to coronary disease? Well, think about gout. Over the years, you've been depositing crystals of uric acid in your joint, and all of a sudden, with a fever or a night in the town, you have an acute event. Likewise, with coronary disease, you're depositing cholesterol in your arteries over the decades, and all of a sudden, you have an acute event. Are NLRP3 and NADPH oxidase relevant to atherosclerosis? They certainly are to gout. Are they relevant to atherosclerosis? If that's the case, then there might be a role for colchicine in the treatment of coronary disease. Now remember, inflammation, oxidative stress drive cardiovascular disease just as they drive gout. And oxidative stress is the kindling and the bonfire of acute gout. Could it be the kindling and the bonfire of acute coronary disease? What are colchicine effects on Roberts's rules? Now, if we lower oxidative stress and we lower inflammation, this should have favorable effects on these other effector arms that are driving cardiovascular disease. Let's start with an animal study. Colchicine and statin synergy. 50 genetically normal rats. You're going to put 40 of them on a high-fat, high-cholesterol diet that will produce atherosclerosis and hyperlipidemia in this animal model. After 6 weeks of the bad diet, you randomize the rats to receive atorvastatin. That's a statin. 10 milligrams per kilogram orally. Colchicine, 0.5 milligrams per kilogram with an intraperitoneal injection. Both atorvastatin and colchicine, so you're getting a statin and colchicine or controls. Keep them on the bad diet. At baseline, after 6 weeks of the bad diet, and then at 8 weeks, 8 weeks of the bad diet plus 2 weeks of the therapy, we're going to look at lipids, nitric oxide, C-reactive protein, phospholipase A2. And 10 receive standard diet and only sham interventions. They are the control animals. Okay, so in the normal animals on the standard diet, cholesterol is low. If you put them on the bad diet for 6 and 8 weeks, cholesterol LDL goes up. So after 6 weeks of the bad diet, cholesterol, the LDL is up to 146. You put them on atorvastatin. We know that atorvastatin blocks HMG-CoA reductase, lowers generation of cholesterol, it falls. Colchicine has no effect on cholesterol. Colchicine doesn't lower cholesterol. Combination therapy was still effective. So colchicine did not inhibit the ability of statin therapy to lower LDL cholesterol. Now let's look at nitric oxide. We want high levels of nitric oxide. We know that nitric oxide production is compromised in the presence of oxidative and inflammatory stress. Hyperlipidemia leads to oxidative and inflammatory stress. Remember, when HMG-CoA reductase is inhibited, not only does it make LDL cholesterol, it makes free radical and inflammatory mediators, it leads to endothelial dysfunction. So on the bad diet, nitric oxide generation falters. Now, bad diet plus statin, it improves a little bit. By lowering HMG-CoA reductase, we're lowering NADPH oxidase, less oxidative stress, nitric oxide synthase starts making nitric oxide again as opposed to superoxide, so statins help with endothelial function. So does colchicine. Colchicine restores, at least partially, the endothelial dysfunction due to the high cholesterol diet, and there's a synergy. Atorvastatin and colchicine synergize to increase nitric oxide. Well, that's interesting. C-reactive protein and phospholipase A2 are markers of inflammation. When nuclear factor kappa beta is translocated, we're going to make more CRP and PLA2. Of course, they skyrocket on the high cholesterol diet. Statin therapy helps. Colchicine helps even more, and there's a synergy. Same relationship with PLA2. So statins are lowering inflammation, colchicine's lowering inflammation, and there's a synergy suggesting that they're working via independent pathways, suggesting that there might be additive clinical effects. So the role of colchicine in human coronary disease, actually NLRP3 malactivation plays a role in gout, metabolic diseases such as diabetes, and in cardiovascular disease. We're going to be talking a lot about NLRP3 as we learn more about it and the roles of colchicine in blocking inflammation, oxidative stress in many organ systems. So NLRP3 is an intracellular inflammation amplification pathway. It's the response of the innate immune system to DAMPs and PAMPs, danger-activated molecular patterns, pathogen-activated molecular patterns. So our mononuclear cells have these threat receptors, and if there's a real infection, there's oxidative stress, there's high fatty acids, you will activate nuclear factor kappa beta and make low-level, not yet active, nascent pro-interleukin-1 beta and interleukin-118. So NLRP3 is activated in response to danger signals. So when we phagocytose particles such as uric acid, cholesterol, silica, amyloid, asbestos, aluminum hydroxide, which is now the adjuvant in vaccines, these are particles and rocks and fibers. We can't really digest them like a bacteria. So we have this frustrated phagocytosis. So our response to these crystals and particles is to activate NLRP3 and generate a lot of inflammatory mediators. So if we can block NLRP3 and block the inflammatory response to uric acid crystals, and cholesterol and silica and asbestos are also causing inflammation via this pathway, we could hypothesize that colchicine would be of great value in coronary disease. It might be of value in asbestosis. It might be of value in amyloid, which is playing a role in Alzheimer's disease. Again, this is a danger signal, the innate immune response to danger signals and pathogen-activated molecular patterns. Just remember, danger, Will Robinson, NLRP3 activate. These danger signals lead to an inflammatory response. Crystalline uric acid is a danger signal. Crystalline cholesterol in the artery wall is a danger signal. Now, how relevant is this to cardiovascular disease? First question, the mononuclear cells they phagocytose uric acid and activate NLRP3. Will they phagocytose cholesterol? Well, you can show this. You can incubate mononuclear cells with crystalline cholesterol, and you can label it, and you can show that crystals of cholesterol are phagocytosed by mononuclear cells the same as are crystals of uric acid. Oxidized and unoxidized LDL cholesterol will be incorporated into mononuclear cells. They'll activate NLRP3. You'll get more interleukin-1 beta, more oxidative stress. Now, is there crystalline cholesterol within the intima? I was taught that we see crystals of cholesterol in the vascular wall only in advanced disease. And that's because when I was in medical school and college, we did not have electron microscopy and monoclonal antibodies. We would take the artery and we would apply solvents to it and then dyes and look at it under the microscope. And these solvents would wash out the crystalline cholesterol. So the only marker of crystalline cholesterol was a void. And of course, you needed a big chunk of crystalline cholesterol to make a void. So the teaching was that crystalline cholesterol is not present in the artery wall outside of advanced disease. With newer techniques of microscopy, we are learning that crystalline cholesterol is present in the artery wall very early in the process. These are LDL receptor double knockout mice. They don't have LDL receptors. They have a high cholesterol. If you feed them a high cholesterol diet, they will predictably develop cardiovascular disease. And they are a reliable model of human atherosclerosis. So far, anything that aggravates atherosclerosis in this mouse model aggravates atherosclerosis in man. Anything that attenuates atherosclerosis in this mouse model is of value to man. So these are the mice in the resting state. If you put them on a high cholesterol diet, 2 weeks, 4 weeks, 8 weeks, 12 weeks, you can see that they're filling up with plaque. And if you look at, you can also show that there's a progressive mononuclear infiltrate. So these white cells are entering the vascular wall, and you also are forming up crystalline cholesterol. So crystalline cholesterol forms up early in the atherosclerotic process, and it's pulling in mononuclear cells that are phagocytosing the crystalline cholesterol on the vascular wall. Now, in animal models, you can ablate different genes. So here we have the LDL receptor double knockout mice. They don't have LDL receptors. They have no way of taking cholesterol back to the liver. You put them on a high cholesterol diet, they're going to get atherosclerosis. Now, in this animal, they don't have LDL receptors, so they're susceptible to atherosclerosis, and you knock out NLRP3. So you can no longer mount an inflammatory response to phagocytosed crystalline cholesterol in the artery wall. They have less atherosclerosis. If you knock out ASC, which is also involved in the NLRP3 pathway, there's less atherosclerosis. If you knock out interleukin-1 beta, the key inflammatory mediator that is processed by NLRP3, you have less atherosclerosis. This would suggest, and only suggest, that colchicine or anything else that blocks NLRP3 would actually block the generation of atherosclerosis. That's kind of exciting. Now, NLRP3 expression within the atherosclerotic plaque, is it actually there? We're going to take human arterial tissue, 106 patients undergoing carotid endarterectomy. You scoop out the plaque, you're going to look at it, and then the iliac artery of transplant donors. So these are people with normal hearts, normal cardiovascular systems. They die in an accident and they're giving up their hearts. So you're going to quantify messenger RNA levels of NLRP3 and ASC and caspase-1, and then interleukin-1 beta and interleukin-1 8. Now, transcription factors enter the nucleus, and they cause you to read the genes for certain proteins. And the way you read them, you're making messenger RNA that then leaves the nucleus, goes to the cytoplasm, that is translated into proteins. So messenger RNA means that you are actively reading these genes. So what you see in the healthy individuals that didn't have cardiovascular disease versus those that had plaque, within the plaque you see higher expression of NLRP3, you see more ASC, you see caspase-1, you see interleukin-1 beta, and interleukin-18. And individuals with symptomatic plaques had higher levels of NLRP3 than an asymptomatic plaque. So we don't see high-level NLRP3 in normal arteries, but we do see it in diseased arteries. The more active the atherosclerosis, the greater expression of NLRP3, the greater the generation of the inflammatory cytokines, interleukin-1 beta and interleukin-18. Now, if you can show in this, you can stain these molecules and see where they co-localize. And I stared at this slide for a long time. I couldn't figure out what these colors meant, but that's kind of pretty, so I thought I'd show it to you. But it shows that NLRP3 and its components co-localize with the macrophages, the mononuclear cells, and vascular smooth muscle cells within the plaque. So NLRP3 is involved in the active inflammatory region of the atherosclerotic plaque. Now, is there an interleukin-1 beta in coronary plaque? We'll take coronary tissue obtained from 18 cardiac transplant recipients. 13 had ischemic cardiomyopathies. That means they had heart failure due to severe coronary disease with extensive atherosclerosis. 5 had a non-ischemic cardiomyopathy. They may have had a viral infection. And 4 of them had mild early atherosclerosis. That wasn't the problem, but they were old enough that they had mild atherosclerosis within their artery walls. And here you're going to see those with the ischemic cardiomyopathy, all of them had expression of interleukin-1 beta. On the luminal endothelium, that's the endothelial cells that would be exposed to the flow area, and the adventitial endothelium, that's in the walls of the blood vessels that actually serve the artery wall. Those with the non-ischemic cardiomyopathies did have some interleukin-1 beta, and that's because they had really low-level atherosclerosis, but it was less extensive. Now, the totally normal arteries, the left internal mammary artery and the saphenous veins, had none. So we're not going to see interleukin-1 beta, the product of NLRP3, in normal vessels. We're only going to see it in diseased vessels. The more advanced the disease, the more NLRP3 activation, the more interleukin-1 beta, the more interleukin-1 the more oxidative inflammatory stress. And you can see that the interleukin-1 beta is found in the macrophages, basically the leading edge of the atherosclerotic process. Now, are white cells present? So white cells are generating all this superoxide. They're called in by interleukin-1 beta and interleukin-18 generated by NLRP3. Are they present in coronary plaques? We're going to take coronary tissue obtained from 13 patients with a fatal myocardial infarction. 8 had plaque rupture. So you've got this plaque and there's oxidative inflammatory stress and it cracks and the atherosclerotic gruel leaks into the flow area. You clot off the artery, you have a large heart attack. 5 had plaque erosion. Here, the plaque erodes and it doesn't plug up the artery, but it releases debris that goes downstream. They would have had smaller heart attacks. 45 with non-cardiovascular death, motor vehicle accidents, etc. And then 67 atherectomy specimens. You're going to scoop out the plaque. 35 with stable angina, 32 with unstable angina. And we're going to look for neutrophils, mature neutrophils, and macrophages with monoclonal antibody staining. And now macrophages are the first-line defenders. They're engulfing cholesterol or cholesterol and initiating an inflammatory response and then pulling in the neutrophils. Now, in the individuals that did not have active cardiovascular disease, some had very mild atherosclerosis, diffuse intimal thickening, hypercellular response, fibrous plaque. There was low-level macrophage infiltration. Those with fibrolipid plaques had a little bit more, but the ruptured and eroded plaques had a lot more. You don't see neutrophils outside of unstable plaques. So you don't see any neutrophils with normal vessels or early atherosclerosis, but when you have the unstable plaque with the oxidative inflammatory storm, you see neutrophils and you see these mature neutrophils. Now, if you look at the polymorphin nuclear levels in unstable angina, they're much greater than stable angina. The mature neutrophils are found in the unstable angina. We have a mononuclear infiltrate that calls in the polymorphin nuclear leukocytes that generates all the free radicals. So, of course, you would expect them to be present at greater levels in the conjugated active plaques. So, now, then also I want to talk about endothelial dysfunction. Now, endothelial dysfunction is when the vascular wall stops making nitric oxide, starts making superoxide, you vasoconstrict, platelets get sticky, adhesion molecules are elaborated so you can pull white cells in to enter that area and cause inflammation. And that's bad with respect to coronary disease, but it's an appropriate response to trauma or infection. If you have a focal infection or trauma, you want your endothelial cells to activate. You want your plates to be sticky so you don't bleed out. You want white cells to bind to the artery wall and go in there and gobble up the debris. So we have endothelial activation in gout, and we have pathological endothelial activation in coronary disease. Now, NLRP3 generates caspase to convert nascent interleukin 1 beta and interleukin 118 into the active mediators. It also makes a molecule called HMGB1, high mobility group box protein 1, that causes endothelial activation, because you obviously have endothelial activation in gout to get all that swelling. So NLRP3 does that. So this is a means through which activation of NLRP3 with cholesterol crystals will lead to endothelial dysfunction. Endothelial dysfunction characterizes and drives forth cardiovascular disease. That is why colchicine improved endothelial function, because activation of NLRP3 makes HMGB1, which causes endothelial dysfunction. You can block that with colchicine. That's why endothelial dysfunction on the basis of a high-fat diet was blocked with colchicine, and we would expect that this would hold true in humans as well. So, relevance of all this biology, you had to suffer through all this biology. Now the payoff is the clinical trials that show benefit of colchicine in human coronary disease, but now you're going to understand why it works. Well, colchicine concentrates in leukocytes 50-fold. We know that mononuclear cells and polymorphonuclear cells play a role in cardiovascular disease, particularly acute active cardiovascular disease. Colchicine blocks the NLRP inflammasome. Inflammasome is acted by uric acid and cholesterol crystals, generates interleukin 1 beta, interleukin 18, downstream interleukin 6, and HMGB1. So let's look at some clinical trials. Colchicine and cytokine suppression in ACS, acute coronary syndrome. 83 consecutive subjects undergoing clinically indicated cardiac catheterization, angiography. 40 had an acute coronary syndrome, unstable angina, heart attack, and they were all on statins to block HMG reductase. They're all on aspirin. They're all on ACE inhibitors to block angiotensin II. They're on beta blockers to blunt oxidative stress from catecholamines, standard medical therapy. 33 had chronic stable angina. They had an elective heart cath. Maybe their angina changed a little bit. They had an oral stress test. They're on statins, aspirin, ACE inhibitors, and beta blockers. Now in 10, they really didn't have heart disease. Maybe they had reflux or esophageal spasm. They had only modest or no atherosclerosis, but many of them were on statins, aspirin, ACE inhibitors, and beta blockers. You're going to measure interleukin 1 beta and interleukin 18. Those are products of NLRP3, and interleukin 6, which is a product of nuclear factor kappa beta. But when we make a lot of interleukin 1 beta, interleukin 18, we're going to activate nuclear factor kappa beta and make a lot more IL-6. In the ascending aorta, that's blood leaving the heart to serve the cells of the body. The inferior vena cava, this is used blood. The molecules, the nutrients in the blood have been extracted by cells, and this is what's left over returning to the heart. And in the coronary sinus, this is the vein that drains the coronary arteries. So if something is elevated in the coronary sinus versus the ascending aorta and inferior vena cava, that means it's being generated within the heart itself. You're going to randomize the ACS and chronic stable angina subjects to receive 6 to 24 hours prior to their angiogram, colchicine 1 milligram and 0.1 milligrams 1 hour later. A single shot of colchicine or no colchicine. What do you find? Interleukin 1 beta, an inflammatory mediator, is greater in those with chronic stable angina and acute coronary disease than in those who are normal. The same with interleukin 18, and the same with interleukin 6. Now you'll see in the chronic stable angina, in the arterial and venous levels are higher. So systemically, they're more inflamed. That makes sense. They've got coronary disease versus the normals, and there's more in the coronary sinus. You see systemic and coronary sinus levels rising in acute coronary syndrome. And you can see the gradient between the rest of the body and what is being made in the heart increases in this active unstable coronary disease. The same thing with interleukin 1 beta. Now you don't see much interleukin 6 in the chronic stable anginas. They didn't measure it in the normal people, and you can see an awful lot in acute coronary syndrome. So with coronary disease, you have inflammatory mediator generation, and in unstable coronary disease, heart attack, unstable angina, you're making a lot of this in the heart itself. Now, so what we're going to do here, we're going to look at the gradient of interleukin-1 beta between the coronary sinus and the systemic circulation, and that would represent interleukin-1 beta being generated in the coronary arteries in response to inflammation. Without colchicine, here's the gradient. You give them a single shot of colchicine and you abolish it. They're almost back to the control level. Same thing with interleukin-18 and interleukin-6. So a single jolt of colchicine will dramatically block the generation of interleukin-1 beta and interleukin-18, the products of NLRP3, which is being activated because white cells are ingesting crystalline cholesterol, and you're knocking out downstream interleukin-6, a powerful acute anti-inflammatory effect of colchicine. They didn't look at outcome, but presumably if you treated these patients, they would have a better outcome. That was not the point of this study. But here again, you can see the coronary sinus interleukin-1 beta, coronary sinus interleukin-18. It's chronic stable angina, no treatment. Colchicine, it falls. So it helps in stable angina. It helps a lot more in unstable angina because they have a greater baseline NLRP3 activation. Interleukin-1 beta, interleukin-18, interleukin-6 are dramatically, their expression is downregulated with acute colchicine therapy. What about chronic colchicine therapy in patients with stable coronary disease and high CRP levels? Now, CRP is a marker of inflammation, nuclear factor kappa beta translocation. We don't want to see this. So we're going to take 200 subjects with stable coronary disease. They're all on aspirin, which is anti-inflammatory, and all on high-dose statin therapy, atorvastatin. So HMG-CoA reductase is downregulated, NADPH oxidase is downregulated. You would expect to have lower levels of oxidative stress and inflammatory mediators. Now, despite this therapy, 64 of the 200 subjects had a CRP above 2, which was their cutoff as abnormal. So 22 of them were observed. There was no change in their program. 44 received colchicine, 0.5 milligrams twice a day in their prior treatments. You'll repeat the CRP 4 weeks later. Now, this was a non-randomized open trial, and there were no significant side effects. No one had to drop out of the study due to side effect. And what you see, these are the CRP values at baseline at 4 weeks. CRP fell in the colchicine group. In the observation group, CRP did fall insignificantly from 4.3 to 3.7. It fell more from 4.5 to 1.78 with colchicine. CRP dropped 11% without intervention, 60% with intervention. A final CRP below 2, which they felt would be a good result, that was obtained in 15% of the observation group, 70% with the colchicine group. So we've shown that a single dose of colchicine will acutely block the generation of inflammatory mediators in the coronary arteries. And if we take patients and look at their systemic CRP and add colchicine to statin therapy and aspirin, we get a reduction in CRP. Colchicine, CRP fell in all the colchicine-treated patients, mean reduction 60%. It fell by over 50% in 2/3, and 70% CRP fell to the target below 2. What effect will this have on outcome? Well, we are showing that biology is improving. Oxidative inflammatory stress is improving. We would anticipate endothelial function will improve. Well, we don't really care about that. We care about outcome. What effect will colchicine have on the status of our patients? So here we're going to carry out a randomized double-blind clinical trial. 493 subjects with stable coronary disease, angiographically documented coronary disease. They all had abnormal heart caths, stable for 6 months. 19 had a prior bypass surgery, 58% had a prior balloon angioplasty. They're all on standard medical therapy. High-dose statin, 95%. Aspirin or clopidogrel, which is a Plavix, a more powerful antiplatelet agent, 94%. 2/3 on a beta blocker, 2/3 on an ACE inhibitor. So standard medical therapy, state of the art. You randomize them to receive colchicine, 0.5 milligrams a day or placebo. Now, 22% withdrew from colchicine therapy, 11% in the first 4 weeks, 11% over 2.5 years. And in any new drug therapy, you're going to get about 20% of the patients to drop out due to some sort of side effect or adverse reaction. And the adverse reaction to colchicine is dose-related diarrhea. So those patients that had diarrhea from colchicine dropped out. Now in clinical practice, what we do is we cut back the dose, make it every 2 or 3rd day, but this was sort of all or nothing, so 22% did drop out. Record event rate over the next 3 years, minimal follow-up 2 years, and a double-blind protocol was followed. Neither the subjects nor the doctors knew who was getting placebo, who was getting colchicine. Their primary outcome was a composite of ACS, that's myocardial infarction or unstable angina, out of hospital cardiac arrest or non-cardioembolic ischemic stroke. That would be a stroke from a blocked carotid artery. Freedom from the primary outcome. There was a 67% risk reduction. 16% of those on placebo therapy had an event, 5.3% with colchicine. Dramatic risk reduction, adding in colchicine to standard medical therapy. And all subgroups, men, women, diabetics, non-diabetics, prior bypass surgery, everybody improved. Now, this was with the intention to treat approach. If you just looked at people who stayed on colchicine over the entire 3 years, there was a 75% risk reduction. So if you are on standard medical therapy, you have stable heart disease, we put you on colchicine and you take it for 3 years, 3 out of 4 of you that were supposed to have an event did not have it because we blocked NLRP3 with colchicine. That's one of the most powerful clinical effects we've ever seen in a clinical trial. Components of the primary outcome, acute coronary syndrome. Well, they have an acute coronary syndrome, you're phagocytosing crystals of cholesterol, activating NLRP3, generating an inflammatory and oxidative storm. That's driving the acute coronary event. Dramatic reduction, 13.6%, 4.6. There was no significant effect on cardiac arrest or ischemic stroke because these patients did not have those, but the acute coronary event was dramatically decreased. Now, colchicine did not protect against stent-related events. So if you had restenosis or you clotted off a stented vessel, colchicine didn't help here. But for non-stent-related acute coronary events, dramatic reduction, fewer heart attacks, less unstable angina. So colchicine seems like a great idea. But I did point out it didn't protect against recurrent events due to stent failure. So we wouldn't say that colchicine is an appropriate therapy to block restenosis or events from stents. However, that may not be entirely true. Here we're going to look at the effect of colchicine and bare metal stent restenosis in diabetic patients. 196 diabetics undergoing bare metal stent placement for acute coronary syndrome or chronic stable angina. Now, in the olden days, we did balloon angioplasty. We would just blow up a balloon and scrunch the plaque down, increasing the flow area, you'd have less angina. The problem is there'd be a lot of elastic recoil. The recurrence rate, called restenosis after balloon angioplasty, was 40 to 60% because of elastic recoil. So stents came out about 10, 15 years ago. You put in this mesh, this scaffolding to prevent this collapse of the blood vessel. And with stents, you are far less likely to restenose. Now, the initial stents were bare metal stents, and the problem would be that the immune system would begin to heal that region with scar tissue. It's called neointimal hyperplasia. So the drug-eluting stents came out. The drugs there block proliferation of immune cells, and via that mechanism blocks neointimal proliferation, blocks restenosis. The problem is the drugs and the drug-eluting stents also inhibit repaving of the stent with normal endothelial cells. So for a period of time after drug-eluting stent placement, there's just a piece of metal in the artery, and that's thrombogenic. You could form a clot on that. Therefore, if you get a drug-eluting stent, you need to be on dual antiplatelet therapy, aspirin and Plavix, for at least a year, maybe 2 years in diabetics. With a bare metal stent, the requirement for dual antiplatelet therapy is only 4 months. So in some situations, we would prefer a bare metal stent over a drug-eluting stent. It depends upon the architecture of the narrowing. In addition, if we know that you might need a non-cardiac surgery in 6 months, we wouldn't want to put you on a drug-eluting stent because you couldn't have the surgery. You couldn't go off the dual antiplatelet therapy. Or let's say you have atrial fib and we have you on Coumadin. So if we put in a drug-eluting stent for a year, you need to take the Coumadin, the aspirin, and the Plavix. That's too much anticoagulation. There'd be a risk for bleeding. So in certain situations, you would undergo bare metal stent placement. So they chose, the doctors chose bare metal stents in 196 diabetics that needed stent placement for acute coronary syndrome or chronic stable angina. They all received standard medical therapy and then the dual antiplatelet therapy, clopidogrel, that's Plavix and aspirin. Then you add to standard medical therapy either colchicine, a 0.5 milligram twice a year placebo, and you are randomized to either colchicine or placebo. You repeat the angiogram and do intravascular ultrasound. You put an ultrasound crystal into the artery wall and you can directly measure the plaque volume. Do that at 6 months. you're going to evaluate for restenosis. And if you had a greater than 50% narrowing in the stent, that was considered restenosis from angiography. If the lumen, the flow area, was below 4 millimeters by intravascular ultrasound, that was restenosis. Randomized double-blind protocol was followed. So what you find is that colchicine did protect against restenosis. The degree of restenosis was 43% with controls, 24% with colchicine. So neointimal proliferation that mediates restenosis in a bare metal stent was blunted with colchicine, and with angiographic restenosis, it fell from 33% to 16%. The degree of re-narrowing was not pronounced in either group, more so in the controls than with colchicine, so there was no difference in clinical event rate or the need for repeat stent placement. Perhaps if they'd gone on longer, they would show that colchicine did protect against clinically significant restenosis or the need for a second stent procedure. So there's going to be some role for colchicine with stents. It's not as powerful as the ability of colchicine to protect your non-stented native arteries from plaque activation and an acute event, which would manifest itself as heart attack or stroke or cardiac death. Colchicine and early post-ablation atrial fib. We're seeing far more atrial fibrillation today than we did 10 years ago, just as we're seeing more diabetes today than 10 years ago. And oxidative inflammatory stress is probably playing a role in atrial fib, just as it's playing a role in hyperlipidemia, type 2 diabetes, hypertension, and atherosclerosis. So when you have atrial fib, we will use drugs to try to revert your rhythm to normal. We may use a counter shock, and then when your heart starts up again, it tends to go back to normal rhythm. Increasingly, we're using the fibrillation procedure because the fibrillation procedure leads to a permanent resolution of atrial fib in 70 to 80% of the patients. You go in through the vein with a heart catheter with an electrode tip, you map out the electrical pathways in the heart, and then with pinpoint precision, you will damage the lining of the atria where the nerves are, so you're going to block the abnormal nervous conduction within the atria that allows the atrial fib to occur. And this is a very safe procedure. As a matter of fact, the fib ablation procedure is far safer than the use of most of our drugs. So we're turning to fib ablation increasingly in dealing with atrial fib in our patients. So the problem is it doesn't work in everybody, and some people have recurrence, and then you have to have a second or a third fib ablation. Sometimes it doesn't work at all. What can we do medically to increase the likelihood that the fib ablation will be successful, that you will not return to sinus rhythm? You will return to sinus rhythm. Will colchicine help? So 170 subjects with intermittent paroxysmal atrial fib despite drug therapy. You stop their antiarrhythmics for 2 months, do the baseline lab studies, do the fib ablation. All receive anticoagulant and prior standard therapies for 3 months post-ablation. You randomize the patients to receive over 3 months, beginning the day of the ablation, colchicine, 0.5 milligram twice a day, placebo twice a day, monitor lab studies, and evidence for fib recurrence over the ensuing 3 months. Now, 170 subjects underwent fib ablation, and the colchicine group did have more side effects. 12% discontinued, 6% discontinued placebo therapy due to side effects. It was primarily diarrhea. But most of the subjects were able to take at least 2 months of colchicine and get a clinical effect. So, recurrent fib at 90 days, recurrent fib occurred in 34% of those on placebo, 16% on colchicine. Colchicine was effective. Predictors of atrial fib recurrence: high blood pressure, a dilated left atrium, higher levels of C-reactive protein, interleukin-6, inflammatory mediators on day 1 and day 4. The lower your CRP and interleukin-6 on day 4, the less likely you are to have a recurrence. And of course, if you were placed on active therapy, your risk was reduced significantly. 16% recurrent fib with colchicine, 34% with placebo. Now, how does it work? Now, if we look at CRP and interleukin-1/6 inflammatory mediators, there's a slight fall between day 1 and day 4. With placebo therapy, there's a much more significant fall from 5.5 to 3.6, 3.2 to 2.6 with colchicine. If we look at the recurrence rate of fib at 3 months, in relation to what your interleukin-6 level was on day 4, those in the upper quartile, the upper 25% for interleukin-6, 58% had recurrent fib. In the third quartile, 37%. In the first and second quartiles, they didn't have recurrence. So inflammation, as manifested by interleukin-6, seems to be playing a big role in recurrent fib. Atrial fib, in part, is an inflammatory illness. We know that fish oils help. We know that vitamin C will help. And it appears that lowering inflammation with colchicine is also going to help. Colchicine and skeletal muscle ischemia reperfusion injury. 21 genetically normal rats. You're going to create skeletal muscle ischemia reperfusion injury. You're going to ligate, you're going to close the right femoral artery, the artery serving the leg, for 3 hours. So during this time point, there's no flow of oxygenated blood. There's going to be a lot of ischemia. You reperfuse over 2 hours. You open up the artery. You're going to sacrifice and evaluate muscle histology, what it looks like under the microscope, and lab values. Randomly allocate these rats to sham surgery, ischemia reperfusion only, ischemia reperfusion injury with 1 milligram per kilogram of colchicine intraperitoneal prior to ischemia, prior to femoral artery ligation. Now, these are what the normal cells look like. With ischemia reperfusion, they don't look the same. They're smaller, they're deformed. This was the group that had ischemia reperfusion with colchicine therapy. Muscle edema, swelling due to endothelial activation, transudation of fluid out of the vasculature into the tissues increased with ischemia reperfusion. There was an attenuation with colchicine. Muscle damage, what it looked like under the microscope, was attenuated with colchicine. Malondialdehyde is a marker of oxidative stress. You're oxidizing the cell membrane lipids, and this would be akin to LDL oxidation, attenuation with colchicine. Superoxide dismutase degrades superoxide. When we are flooded with superoxide, we will use up our superoxide dismutase. So this is a marker of intensive oxidative stress. So you see a drop in superoxide dismutase with ischemia reperfusion injury. There's an attenuation with colchicine. Myeloperoxidase is another marker of oxidative stress. Colchicine attenuates it. Interleukin-1 beta in the muscle, and you need NLRP3 to make interleukin-1 beta, and of course you're going to have less with colchicine. Now this study was done with skeletal muscle, but when you have a coronary artery event, you close off your artery, you're having ischemia, you get to the hospital, the artery is opened up with balloon angioplasty or stent, you have ischemia reperfusion injury. So that's very similar to this animal model. A study was done in animals of cardiac ischemia reperfusion injury, and colchicine didn't help, except they gave colchicine late after the event. Here they gave colchicine before the event, and it minimized the muscle damage and the oxidative stress with ischemia reperfusion injury. We would expect the same thing in humans undergoing ischemia reperfusion injury, such as with if you have a heart attack that is aborted with a stent, or if you are undergoing open heart surgery. When you're undergoing open heart surgery, the heart is starved of oxygen for a period of time, you have oxidative stress, and then you reoxygenate. We would anticipate the colchicine would help. Other antioxidant substances, including allopurinol, which we'll talk about in the next section, also decreases ischemia reperfusion injury in heart attack and in patients undergoing open surgery. So allopathic cardiology, the practice that I was trained, focused on anatomy. We focused on fixed blockages and lesions. Cardiology had to do with supply-demand mismatch, and my focus was on doing angiograms and then resupplying oxygenated blood with balloon angioplasty, stents, bypass surgery, later ECP. If we could not open up the artery, we would use drugs to decrease heart rate, blood pressure, contractility, decrease demand. Cardiology was all about supply-demand, fixed lesions. That approach to cardiology, which sort of brain-in-the-box cardiology, that was what I was taught. That's all I did the first 5 to 10 years. I got brain out of the box, and now I'm focusing on the causes of cardiovascular disease and disease in general, inflammation and oxidative stress. We can deal with oxidative stress with antioxidant support, lifestyle modification, detoxification, and blocking radical generating enzyme systems. And we've been talking about the ability of colchicine to block NLRP3, which will block NADPH oxidase, nuclear factor kappa beta, and block the oxidative storm that characterizes acute coronary disease. What are the effects of colchicine on Pauline's pentad or Roberts's rules? Oxidative stress is reduced, inflammatory stress is reduced, endothelial function improves. Clinical use of colchicine. Accepted benefit, treatment and prevention of gout. Familial Mediterranean fever and Behçet's disease are seen in individuals who live in the Mediterranean region of the world. This is a genetic condition where NLRP3 is upregulated, and these individuals experience chronic inflammation due to NLRP3, chronic upregulation, and colchicine is of value. Pericarditis. Following open heart surgery, you can have inflammation in the pericardium, the sac that surrounds the heart. Post-pericardiotomy syndrome refers to pleuritic pain, inflammation in the pericardium and the pleura due to the surgical incision. And colchicine will help with that. If you have any cause of pericarditis, an acute inflammatory process in the pericardium, colchicine is our first-line therapy, and we've accepted this for years. The cardiovascular demonstrated benefits that we're talking about: acute reduction in coronary interleukin-1 beta, interleukin-18, and interleukin-6 in patients undergoing heart catheterization. If you add colchicine to aspirin and statin therapy, you will lower CRP in patients with chronic stable coronary disease. Event rate reduction in stable coronary disease up to 75% over 3 years when you add colchicine to standard drug therapy in patients with stable coronary disease. It will blunt to some degree restenosis in diabetics undergoing bare metal stents, and it helps prevent recurrent fib following ablation. Experimental positive effects: atherosclerosis initiation and progression, that with the LDL receptor double knockout mice. Absence of clinical benefit: it does not block restenosis post-PTCA because that's elastic recoil. In patients with heart failure, colchicine will lower inflammatory mediators, but it does not improve outcome, nor we would expect it to, because NLRP3 is activated in response to frustrated phagocytosis of crystals of cholesterol. That really wouldn't be playing a role in heart failure. So how do we use it? The standard dose is 0.6 milligrams once a day. It's available in tablet or capsule form. Colchicine used to cost pennies a day, and we've been using colchicine for 30 years. Someone at the FDA was troubled by the fact that we don't have any studies that demonstrate that it works in gout, and they wanted to have a study to show that it works in gout. Now, everybody knows it works in gout, but no one has ever proven it. So they went to the pharmaceutical industry and said that if a drug company would do a study that shows that it works, they could get a limited patent. So they did a study and they showed that it worked. No big surprise. So now colchicine is back on patent, and it's incredibly expensive, which is a huge barrier. And I don't think that the FDA, that this action was really in the best interest of Americans. So now colchicine is rather expensive. There's two brand names, Colcrist and Mitigare. So when I write the prescription, I write for colchicine, either Colcrist or Mitigare. And the reason I do that is patient A's insurance company may favor one, patient B's may favor the other. So if I write for the wrong one, they just reject it. So I say either one is okay. If the insurance company balks, I send them that article showing the 75% decrease in event rate, and I send a little note saying, gee, maybe I'm old-fashioned, but decreasing the risk of this patient having a heart attack or a stroke by 75% seems like a good idea, and they always give in. So if I write that letter, insurance companies will not deny coverage for colchicine. And this patent that the FDA gave these two drug companies is not a strong patent. I believe in a few years, colchicine will be purely generic, and then the cost will fall. Now, what are the side effects? 10% of subjects will experience diarrhea, 5% nausea, and I decrease the dose. Remember, it's working in the white cells. It concentrates in the white cells 200-fold with a long half-life. So if you take like a 0.3 milligrams a day or 0.6 every 2 or 3 days, you're still getting a benefit. So I will adjust the dose to provide tolerance. There was concern that if you add colchicine to statins, you're going to get more statin myalgia, statin muscle pain. But that appears not to be the case, because in every study I presented, colchicine was added to statin therapy. There was no increase in myalgia. Now, we metabolize drugs in the liver via the cytochrome P450 system. And many drugs, including colchicine, go out through CYP3A4 and and P-glycoprotein. So if you're taking drugs that go out through those pathways, you sort of use up your detox capacity, and then the colchicine dose would last longer. Conversely, if you're taking colchicine, you might require lower doses of other drugs that go out through these pathways. As a general rule, we would use lower doses in caution with strong inhibitors of CYP3A4 or P-glycoprotein. These are drugs that my patients typically don't take: cyclosporin, clarithromycin, ketoconazole, ritonavir, but long-acting verapamil-diltiazem calcium blockers my patients do take. So I would start maybe with a lower colchicine dose and then titrate it up if you're taking these drugs. No issue with azithromycin, which is Zithromax that we often use for respiratory infections, or grapefruit juice. So there really aren't important drug interactions. The ones that I would be looking for would be long-acting verapamil-diltiazem. So that concludes our presentation of colchicine and cardiorheumatology. Now, I'm going to give you all the references to the slides that I presented at the end of our three-part presentation, and I want to just speak briefly about methotrexate and the CERT. Now, we're involved in the cardiovascular inflammation reduction trial, a randomized double-blind study of variable dose methotrexate versus placebo. We anticipate to enroll 7,000 clinically stable heart attack survivors with metabolic syndrome or type 2 diabetes, and we're going to add either methotrexate or placebo to standard post-MI therapy. Now, why would we be studying methotrexate? Methotrexate is traditionally used to treat rheumatoid arthritis, and it's quite effective in the treatment of rheumatoid arthritis. It was observed that rheumatoid patients who take methotrexate are less likely to have a heart attack or angina than rheumatoid patients that are not receiving methotrexate. That led to investigation of the potential benefits of methotrexate in coronary disease, because autoimmune disease and cardiovascular disease are both characterized by a maladaptive response to the immune system to perceived infection. In rheumatoid arthritis, it's in the joint. In cardiovascular disease, it's in the artery wall. So it's logical that methotrexate might work. So we have patients in this study, and it's a double-blind study. Neither you or I or Laura, our research coordinator, know who's getting methotrexate or who's getting placebo. We're going to follow you for 5 years, and we anticipate to see a decrease in cardiac event rate with methotrexate. And this will be very exciting because methotrexate is an old, cheap drug. And if this works, we're going to have a new member of our therapeutic armamentarium. So now let's move on to the next section, which focuses on allopurinol in cardiorheumatology. Thank you for your attention.